So I'll just start by saying good afternoon, everybody, and welcome to this Lunch and Learn. I'm pleased to say we're being joined today by Lindsay Oliver and Helen Kleiser, who are going to be talking to us about developing a personalised proactive care toolkit with primary care networks in North Cumbria. And on the next slide, this is just a little overview about the Lunch and Learn sessions that are delivered to you from Boost and North Cumbria Integrated Care Library and Knowledge Service. They are a space for health and care staff to just come together to share any experiences, learn something new relating to health and care, with a focus on a quality improvement project of some description, and of course to be signposted to any further resources that you might find useful. And the next slide is just our protocols for this session. So we do ask that webcams are on at the very beginning, but then turn off whilst the presentations are taking place. And please make sure that you're on mute when you are not speaking. You can use the chat function to post any questions or indeed any comments throughout the presentations, and we'll try and pick those up at the end. Please listen with respect and obviously be present and teach this forward. Share it with colleagues in your wider networks. We are recording, so the recording will be available pretty soon after this event on the Boost YouTube playlist, so you can watch again or also share it with colleagues in your wider networks. And so that's enough from me. I will hand you over to Helen and Lindsay, and they'll take you through their personalised proactive care toolkit.
Great, thanks very much. This was a huge piece of work that we did, and in 20 minutes we're not going to do it justice, but we wanted to really point you in the direction of the proactive care toolkit that we've developed with PCNs in North Cumbria, and to share sort of a little bit of context and background to what we did so that that comes to life and makes sense. The last slide includes a link to the toolkit, which you can obviously take photographs of and access quite easily from our Year of Care website. So in terms of what we did a collaborative piece of work working with two PCNs in North Cumbria who are Keswick and Solway and Carlisle Healthcare. And that piece of work, from our point of view, had us working with them from 2022 to 23. The proactive care teams are now established and delivering this on an ongoing basis. But our role was really to work with the PCNs to develop a structured approach to proactive care and develop the associated resources, training and facilitation to help implement it. It was delivered by small teams of staff wrapped around primary care in PCNs, and the focus was very much on delivering that in a person-centred approach. So in a sense, we were developing care plans with people rather than for them. In terms of impact, we weren't really looking at the impact of this way of working because there's lots of research to show that it's a good thing to do. We were actually looking at the feasibility of implementing it and thinking about what needs to be in place to make it work successfully. And we based it on our Year of Care approach, which we've used in primary care for people with single and multiple long-term conditions. And use some of the principles to redesign that for a different group of people who are getting their care in more of a community setting. So as part of the toolkit, you'll see that we thought about how we identify people, what the pathway can look like so that it's structured, intentional and personalised, the things that will make a difference to how well it works, and to really support some sort of regional learning, which is being distilled down into this toolkit that we have. So in terms of proactive care, there's lots of national guidance around that. We worked with something called anticipatory care guidance at the beginning of the project, which was reframed into something called proactive care latterly, which is about working proactively with people who have moderate or severe frailty and have more complex needs. Offering them personalised care delivered by a coordinated multidisciplinary team. The main aims of that care are to preserve health and be preventative, to maintain people's independence, and where possible avoid exacerbations of ill health and use of unplanned care. And in a sense, the guidance set out some components of proactive care, which include actively looking for this group of people and identifying them, completing a comprehensive holistic assessment, which is evidence-based in terms of practice, having a personalised care and support plan and conversation that creates a plan based on the person's preferences and ideas, and the idea of that care being much better coordinated, delivered through multidisciplinary teams who aim to provide some kind of degree of continuity for the person. So that's great. Those are all good things to aspire to do. But really what we're looking to work out as part of this programme is how do you do that in real life, take the component parts and actually build a model to deliver it. And that's what we share within the toolkit. And again, it's all based on the national guidance. And of course, we did this quite a few years ago now. All the teams continue to do work in this way, but it really fits with what we've seen in the 10-year plan, this idea of moving or helping people have their care in the community. And they focus on prevention and proactive care rather than actually stepping in when it's too late and things have happened and deteriorated. And of course, this way of working has huge implications for the workforce in terms of extending their roles, where they work, and how they work together well, so that actually we create something that's much better coordinated than perhaps we do at the moment. So when we started to explore this programme and we were working with the 2 PCNs, we used the original year of care process and principles to develop the process for this group of patients. And that particular way of working takes the annual review for long-term conditions in a primary care setting, combines them so that you actually don't do separate disease reviews, and separates the activity out into an information gathering visit in which all the tests, tasks and assessments are done at a single visit, but which is followed up by a planning conversation with the individual, which helps them navigate their health, understand things better and make decisions based on how they're doing. And they're helped to do that by having preparation materials which allow them to write down their thoughts, ideas and questions, but also see their personal data in terms of their health, things like their HbA1c for diabetes or their blood pressure or their kidney status, so that people can really make informed decisions with a healthcare professional and create a plan that looks forward and anticipates problems rather than just reacting to them. So in a sense, this is an established process that works in many practices, and we wanted to use these principles to inform our programme of work. And in fact, one of the PCNs that we worked with in Carlisle had already been using this process as part of their planned care for people with long-term conditions. And it was a matter of extending it and thinking about how it could be different for this particular group of people. So who is proactive care for? Well, according to the guidance, it's particularly focused on people with moderate and severe frailty who are at risk of health deterioration. And by default, many of them will also have long-term conditions, probably multiple long-term conditions and associated polypharmacy. Potentially those people are becoming high intensity users, in part because they become more reliant on emergency and unplanned care, but in part because we provide care in disease silos and in different locations that sort of fragments things and means that people have quite a lot of care to navigate across the system. And equally, health inequalities falls often into this group of patients, and the proactive care group really sort of is an amalgam of these groups of patients who we look for before they start to deteriorate and have problems. And when we began to look at with the PCNs at the kind of people that we were going to be working with, someone like Eric typifies that. So they're getting older and frailer, they've already got multiple health conditions, and they're starting to have some sort of functional difficulties such as recurrent falls or UTIs, which start to tip them into hospital and needing much more urgent care. As a result of that, they end up with an array of different professionals and appointments to navigate, visits, phone calls, appointments at hospital, appointments with a practice, and things feel quite fragmented. They begin to lose confidence, becoming more isolated because of their functional difficulties, and often really don't get to see the totality of everything that's going on with their health and understand it as a complete sort of suite of things, nor do they always, with all the different professionals, get the chance to talk about the things that are really bothering them. So in a sense, Eric typified the kind of group of patients that we'd be working with as part of this programme of work. And when we mapped Eric's care following hospital admission, we kind of saw this. It's the chaos that we create within a healthcare system for people by giving them different appointments on different days, by having follow-up from hospital in outpatients, having their usual care as well as their sort of reaction to their sort of recent events. And what we noticed was that people would have many different contacts, up to 24 in this case, who from different professionals who all did their own separate assessments. So quite a lot of time spent giving information about Eric to people, but not necessarily much time for Eric to talk about his concerns or get what he needs from the system. So we really wanted to try and calm this chaos down and create a much more coordinated approach that met Eric's needs, but also created a great clinical system of care as well. So with the two PCNs, we created these principles for proactive care, and we came up with the do's and the don'ts of the things that we wanted to achieve as we put this process in place. So we didn't want to wait for things to go wrong. We didn't want to create dependence on healthcare systems and individuals, or to take over people. We wanted to get rid of the duplication, and we wanted to make sure that we weren't just ticking boxes. We want to make sure we have a meaningful opportunity to have a conversation with Eric about what matters to him. So in a sense, we developed some principles of the way we wanted to work, which have been really important to ground us in how we then did things, how we went about working to create a system of care that would work well for Eric. So good proactive care should notice people who are living with complexity and are becoming more dependent on unplanned care. It should provide preventative support much earlier that actually allows things to be managed and anticipated rather than to let go and happen. It should include good clinical care, so looking at the long-term conditions, polypharmacy alongside the functional issues that Eric might be facing. And most of all, we want to take away some of the duplication and coordinate things better, and think forward with Eric. How does he want to live his next few years? What are the things we need to anticipate? What about his preferences for the future? So in a sense, those were the things that we're trying to build into our processes that we created with the PCNs. So to start with, we had to begin to identify people. There is a radar case finding tool for the proactive care group, which sadly was quite late in its arrival into our programme. So the PCNs actually came up with their own list of criteria that they use to identify people based on local intelligence. So, for example, people who were no longer able to attend the practice for their primary care long-term conditions reviews, people in the practice noticing people who seem to be struggling a little bit more and turning up for more unplanned care with the practice, people who've recently been bereaved, or people we'd never heard of because they were over 80 and didn't seem to have used any health services. So actually using both of these methods was a really good way of kind of being pragmatic and practical, and making sure that the practice and PCNs had some ownership over what was done. So a combined approach was best. There was some issues with the case finding tool, and that was mostly due to the accuracy of coding within the primary care systems, particularly in relation to frailty and how that's coded, but also using postcode as a measure of health inequality was really, really inaccurate. And it was really, really important to make the whole PCN aware of what the work was and the patients that could be generally getting a good service from this support. So there were lots of things we needed to do to really make sure we got the right people into this service, including making sure we let people really know what this service was about, what the benefits would be for them as individuals as they used it. And all of these PCNs had to build a proactive care team. Some of them used the ARS funding and some of them used money from under resource GP roles that hadn't been filled. And we came up with some recommendations about the teams of people who should be doing this work as a result of the work that we did. One of them was that we need to design the actual team around the people we serve, and therefore having that sort of data intelligence to look at your proactive care group is really, really useful. It was also important that we had a dedicated proactive care team. Where we didn't, the urgent care often triumphed and took over, and the proactive care really got set to one side. So really making this a slightly separate or dedicated service was important. This really wrapped around primary care very well. So having it aligned to PCN geographies worked well, with flexible arrangements between organisations so that staff could extend their roles and work within that setting. And because these teams were new, they had training needs in terms of developing their knowledge and skills. Clinical leadership was really important, making sure we kept our vision around the purpose of this work, and we didn't stray too far away from that as we started getting into the nitty-gritty of how we did things. Making sure we had good leadership, including senior medical support around the complexity of some of these patients, thinking through their prognosis, some things to do with advanced care planning, but also, I think, in many instances, holding that risk that some of the more newer team members really struggled with. And it worked best when everyone was using a single shared IT system, which in this case was the primary healthcare record. In terms of establishing the team, as mentioned, they're new to this, not necessarily new practitioners, but new to this way of working. And it's a completely different headset when you're working proactively with people to working reactively with people. You need to decide on who your team members are going to be and give them time to get together and work as a team, with links into urgent care so that there's a seamless joining up between those sort of services. And finally, we thought it was useful when teams could be co-located, preferably when primary care have dedicated time to work together and talk about patients, and in a sense draw on the expertise of other members of the team to extend their roles and avoid the need to send off many more separate appointments and referrals to other agencies and disciplines. So true interdisciplinary team working. And when we looked at the sort of skill mix of the team, we felt it was really important to have a small core team who get to know the patient well, who draw on the wider group around this in this model, the expertise and support, or to particularly support patient with a specific issue. So the core team that we had were care coordinators. They were critical to the role and really required quite a lot of support to develop their skills. Admin was important, it always is. And we had senior nurses with experience of frailty and long-term conditions. In this instance, working with occupational therapists who supported much of the work around frailty and extended their work into long-term conditions. And as I say, a senior medic in the team to support that sort of big picture thinking. So in a sense, the knowledge and skills of a team to work with people like Erica or long-term conditions, frailty, polypharmacy and medicine management, really important to integrate that into this. Social prescribing, because that's a big issue around things like loneliness, advanced care planning, because it's part of what we should be doing, and then this idea of care coordination. So I'm really romping through this, but all of these slides, all of this information, along with tips, etc., are in the toolkit. So I'm going to pass you now to Helen, who's going to describe the process and some of the resources.
Thank you, Lindsay. Yeah, so we've heard from Lindsay a little bit about the what, the background, we've heard about the why, and we've heard about who it's for. So I'm just going to take a few minutes, as Lindsay said, just to take you through the how. So just to think a little bit about the process. And as Lindsay said, this was developed with our colleagues over in North Cumbria, and based on the Year of Care approach, and much more detail is in the actual toolkit. So I'm just going to give you a brief overview of each step, but hopefully after this webinar, you'll be able to familiarise yourself with the toolkit and the resources. So literally just going to go through each stage. So I'm not going to say too much about identification because Lindsay's already touched on that. And the identification really is about just working out who proactive care is for. And as Lindsay said, for the sites that we worked with, that was very much about using local intelligence and using local criteria to kind of, you know, find the people. And if you can just click on for me, that would be great. Thank you. And the next again. So then the next stage that takes us into the kind of, I suppose, main cycle of the process, if you like, is what we call preparation. And there's a few different bits of preparation. I suppose the first bit really is about how we prepare those who are, you know, appropriate for proactive care for the process. And so this involves inviting them. Now, essentially, this is a proactive offer, so it is essentially cold calling. So we did spend a lot of time thinking about how we present that to people, the language that we use. And what we came up with really was an initial phone call from the care coordinator or a key member of the team who would describe the offer, explain that it was kind of linked to the GP practice and the benefits really of being within the proactive care service. And then this was backed up with written information to support that. So the written information was a letter about what it might entail and also some information about the team and what to expect at each different stage. What we also sent at this point was what we call a preparation prompt. So a written tool where the person could actually just have the opportunity to talk with their family member, their carers, think about how it is that they're kind of managing with their health, what are their concerns, what are the things that are important to them. So they've got time to think about that before they actually meet with a member of the proactive care team. And the other side of preparation, of course, is about preparing patients, but it's also about the professionals being prepared. So in terms of professional preparation, this was just about familiarising themselves with their clinical record, talking to team members who might know them, understand what's kind of going on with their health as much as possible, and you know, whether they've had any kind of recent admissions. So that actually when you go to the first information gathering appointment, both parties feel that they are prepared for that discussion. So the information gathering appointment, typically completed by the care coordinator and typically done within the person's own home. And it's exactly what it says on the tin. It's an opportunity to learn about the person, to get to know them a little bit. It's very much about building relationships between the patient and the care coordinator, for the care coordinator to understand a little bit about someone's life story, but also just to start to gather some information as part of holistic assessment. And because a lot of the people in the proactive care cohort living with frailty, these are kind of informed by comprehensive geriatric assessment. So, you know, having meaningful discussions about how they're getting on with things like their day-to-day activities, what's their social support like, their psychological well-being. So it wasn't necessarily going through a tick list of an assessment. It was about gathering that information in a real conversational way, ideally led by the preparation prompt. So the hope was that the patients would bring the preparation prompt, this information gathering meeting, and they would be able to kind of prioritise the things that the person has highlighted. As part of this, because really the proactive care process was about bringing together all of the person's needs, we might also do some tests and tasks associated with long-term condition monitoring, you know, blood pressure, foot checks, bloods, whatever that might be. But it's just an opportunity to really get to know the person. And hopefully by the end of this appointment, there'll be a real awareness of the person's strengths, their vulnerabilities, will be a real understanding of what the person's concerned about, what are the things that they want to know more about or that we know wish to happen, but also an idea from the professional perspective of the things that we could maybe start to help with or things that maybe we might be concerned about. The idea being that all of that information can go back for an MDT review. These people are living with, you know, high levels of complexity, and so we need a range of expertise really to be able to support them. So having that MDT wrapped around the core team, as Lindsay showed, was really important. Being able to go back, talk to the MDT and think about what are the things that could help to make a difference. And this was not about making decisions for people. This was very much about just trying to create some options using the MDT expertise. So what are the things that might help? Is it about medication changes? Is it about social prescribing? Is there some, you know, referrals or targeted therapy that might help? What could be the options that we could maybe take back to discuss with the person? This MDT review as well, there might be some discussion about who is best placed to do the care and support planning conversation. As Lindsay said, in the teams that we were working with, that was typically a nurse or an allied health professional or occupational therapist. And they would go for the second appointment, which we call the care and support planning conversation. And you'll notice really there's two distinct stages, I suppose, in this initial bit. And that's really very much about separating out assessments from the planning conversation so that actually both are given equal time and equal value because they're both really important in the proactive care process. And this conversation is very much about planning, about the person and the healthcare professional coming together to bring their own kind of expertise and thoughts about actually what could make a difference, trying to work collaboratively to think about the best plan. And that discussion would typically include lots of different aspects, but it may be things like knowing who to contact if they become unwell, what to do if they start to become unwell, what are the things actually that we can support with or they can do in order to self-manage on a day-to-day basis, and also just a really clear record of what the professional is going to do to support them as well. And hopefully from that conversation, what comes out of it is a really meaningful plan, and it's a plan that's written for the person that they can follow. After that, you'd obviously have this ongoing review, so making sure that the plan is right, amending it, changing it, and ongoing care coordination. But the key thing here is that the person would have a key contact within the proactive care team, somebody who would be their care coordinator, who could help them to navigate through all the complexities of the system, and also they're not discharged. Actually, they continue to be on the proactive care caseload until the end of their lives. So there were some tools that we developed as part of this. If you can just flick on for me, Lindsay. So on the left-hand side, I know it's quite small, it's difficult to read, but we developed a top tips document, which essentially is just some top tips around if you're calling somebody to invite them for proactive care, actually what kind of language might be helpful to support meaningful engagement. On the right-hand side, you've got an example team leaflet. And the middle one is the preparation document that you can send to people in advance of the information gathering appointment for them to think about the things that they might like to discuss, the things that they might want to bring to that appointment as well. And if we skip to the next slide, this is an example of the care and support plan that the teams are using. So there are two key aspects to the plan. So one is that it's used for professionals because unfortunately our systems are not advanced enough yet to be able to talk. And so it was deemed that it was really important for professionals to have access to information, particularly in an emergency situation. So within the plan, we had information for, say, paramedics, which is what does normal look like, what's important to me in an emergency situation, who can you contact in an emergency situation. For the person, it had their plan, their self-management plan, the things that they could do day to day, the kind of support that they were going to get, and a documentation of what their key professional was going to do for them. And then there was also this bit about what they could do if they became unwell. And I think the key bit really to say is that as part of this, we did consider advanced care planning and actually just starting to think about having those discussions, much earlier. So thinking about things like lasting power of attorney, advanced decisions, emergency healthcare plans, actually trying to make sure that those are in place so that the person's voice is always heard at the right time. So I'm just going to take 1 minute or 2 minutes just to give you a little bit of a view of what the toolkit actually looks like. So all the information Lindsay and I've presented is in the toolkit. This is what the toolkit actually looks like. This is the front page. If we go to the next slide, you'll see this is the navigation pane. And so it's got all the relevant sections that Lindsay and I have touched on today. So you can go through those and at your leisure and familiarise yourself with those. All of the slides are kind of set out in a similar way within the main body. So you've got a little bit about what it is, a little bit about example of how it can work in practice, and then top tips. And those top tips are really just the learning that we've gained through going through this process and, working with people who are trying to put this into practice, just as a way of being able to support any organisation that might be looking to implement this in practice. And at the top, you've got all the navigation, so you can move seamlessly through all the different sections. Some of them have got more top tips than others. So if we flip to the next slide, you'll see on workforce planning, there's a bit more, but it's just to do with the level of detail and the information that we felt was really important to share. So we obviously wanted to make sure we shared as much learning as possible. And on the last slide, which maybe is the most important slide of all, is the actual link for the toolkit and a link for our homepage where you can access any of the resources that we've mentioned here today. So, we've got 1 minute to spare, but I would just like to say if anyone's got any questions, we'd be willing to answer them.
Thanks very much, both of you. That's a really comprehensive introduction to that toolkit. And I think we'll all agree that real, genuine, personalised approach to care is absolutely key to engaging our local population with their own health and well-being. We do have one question from Yolanta, who's asking, how soon can you implement this? At present, GPs decline taking blood tests to optimise patient care and speed transfer from hospital to community, and pharmacy services are very restricted, which delay discharges.
Gosh, that's quite a big question.
Yeah.
I suppose really the PCNs that we worked with wanted to do something good for their patients. And to some extent, some of the blood tests and things that are taken have to be taken for their long-term conditions care as well. So in a sense, we're working with some willing practices who still struggled in terms of resource and urgent care being something that is pushing us to do things in a certain way, but is very reactive. So we felt and discovered it was worth working with PCNs who could see the problem, wanted to have some better for the practices, and had some resource that they could either shift from the hospital or using their Rs funding to do different work. It didn't really require an awful lot of GP input, but it did require some, partly from a clinical governance point of view and partly from the point of view of just having that oversight and that permission that this was a service that was linked to GP practice and therefore something that you should think was a good thing to go to. I don't know, Helen, how would you add that? I mean, it's a...
It is a really tricky one. I think it comes back to that bit at the beginning, doesn't it, about having coherence about what you're doing and why. And actually, that's where I suppose that just comes from the desire to change.
Okay, thanks very much. I'm aware that we're just rapidly running out of time. So thanks to both of you. People can reach out after the event if they do have any further questions, but the recording obviously will be available. And just on the next slide, your feedback is always welcome. You will be emailed an evaluation form that might just take a couple of minutes of your time just to let us know your feedback around the session. And on the final slide, I think we have the get in touch with us, info@boost.org.uk. If you have any ideas for topics or speakers that you would like to suggest for any future lunch and learns. And in the chat now, there is a link to the next session on the 22nd of October about compassionate leadership, and the 18th of November, supporting personalised care, maternity and neonatal care. And the Newcastle Community Health Bus Collaborative Clinics is on the 9th of December. The link is there if you'd like to register for any of those sessions. So thank you very much, Helen and Lindsay, for your time today. And thank you very much everyone for attending.